അച്ഛാ
ഉം.
6 ദിവസത്തെ ഇടവേള കഴിഞ്ഞ് ഡെവിക്കർ വന്നിരിക്കുകയാണ്. ചില കാര്യങ്ങൾ പറയാനും ചില കാര്യങ്ങൾ പഠിപ്പിക്കാനും.
ആഹാ. ഓഹോ, അവന്റെ ഒടുക്കത്തെ ഒരു ഡയലോഗ് എന്റെ കയ്യിൽ എസ് മോഡൽ കത്തില്ലാണ്ട് പോയി, ഇല്ലെങ്കിൽ തന്നെ അരിഞ്ഞ സവാള ഗിരിഗിരി ആക്കിയിട്ടുണ്ട്. എന്താ വരുന്നത്?
Sorry guys, hope that was a fun and quirky intro. Welcome to another episode of Devikar's Vodcast. How are you guys doing? Hope you're doing well.
അവർക്ക് പറയാൻ പറ്റുമോ? ഇല്ലല്ലോ.
നമുക്ക് പറയാൻ പറ്റില്ല, പക്ഷെ നമ്മൾ അങ്ങനെ assume ചെയ്യും that they're doing good. By the way, I'm Dr. Keith Matthew, and that is our dearest Dr. Arun Nair. And today, we're off to another episode. Thank you for all the support that you've given over the past few days and weeks since we have started. And if you have anything, please let us know. What are we talking about today, Macha?
Today we will be talking about stroke.
Yes, that is right. We're going to talk about stroke. What is stroke?
Stroke, essentially, if we have to dumb it down, it's basically saying that a part of the brain is not receiving blood supply adequately, either due to a clot or due to bleeding out, which results in death of that particular tissue, of that particular part of the brain.
That's right.
So that's essentially what stroke is. And stroke can have a spectrum of symptoms depending on which part of the brain is affected.
Absolutely.
Right.
So essentially, it's a part of a group of disorders that, like for example, a lack of blood supply to the brain leads to stroke. Lack of blood supply to the heart leads to infarction, or what we call heart attack and things like that. Similarly, lack of blood supply to the vessels in the leg would lead to vascular ischemia. So what would essentially, what would be the causes or the risk factors that predispose to developing a stroke? I'm gonna, go ahead.
The biggest ones that we have to keep in mind: high blood pressure, smoking, high cholesterol, diabetes. These are all the sort of biggest risk factors that can play a role in the development of stroke. But there are obviously some rare causes as well.
Right. So all these risk factors, they essentially lead to a common principle called atherosclerosis. Now, what is atherosclerosis? Atherosclerosis is basically the development of a fatty kind of plaque, or it's basically a fat constituting obstruction in the particular vessel. So all these risk factors predispose you to developing that, and that's common across the range actually. And then that would lead to lack of blood supply. Now, essentially, we have the carotid arteries that supply blood to the brain. So when you have, so that's mostly usually where you have atherosclerosis, where there's the narrowing of the blood supply. And that's not the only reason. You could also have embolism from other places that would lead to, again, occlusion of the vessels. So Machan had rightfully mentioned that different parts of the brains are involved. Different parts of your brain, as we know, contribute to different functions. So if you see the frontal part deals with the executive functions, then you have the parietal bit, which are the sides, then you have the occipital side that leads more into vision. So depending upon which part of the brain is affected, we have deficits in those functions. Macha, what would be the different signs and symptoms of, per se, stroke? A person suspected developing stroke.
So obviously, like we said, different parts of different symptoms, but if we have to sort of take a generalized look at this, we can say weakness or loss of sensation can be a common sign in either arm or legs. For example, that's a common symptom. Drooping of one side of the face can be a common symptom as well. Some patients may obviously experience some problem with their vision as well at times. So these are the common symptoms, but for the general public, and also, let's start off for the medical students and graduates in specific, the most commonly affected artery in the brain for a stroke is usually the middle cerebral artery. Right. So in that case, the common symptoms would be weakness, or something sometimes you call hemiparesis, which is one side of the body is affected, which is contralateral to the side of the lesion. So if you had a clot or bleed in the right middle cerebral artery, or the right side of that, you would have symptoms appearing on the left-hand side. So this is and vice versa. So if we remember the mnemonic FAST, that would be very important for the general public to recognize signs of stroke if they ever see anyone experiencing any of the following symptoms. So FAST can stand for what? So what does F stand for?
F stands for face. So changes in the face. So that would be essentially maybe drooping of the face, So changes in general in the face that you could observe, so that could contribute to face.
Facial drooping is
Facial
like
drooping.
one of the
Classic.
key signs to watch out for.
Exactly.
A would do with the arms. So this is something called pronator drift. Okay, so it's when you put out both arms, okay, and you ask the patient or the person who you're suspecting is having a stroke to put both their arms out, and you ask them to close their eyes, and you notice that one arm starts pronating. So obviously this is pronation, this is supination. So pronator drift means involuntarily after the patients close their eyes, their arm starts to drift like that.
Yeah.
So involuntarily, which means if my right arm over here is pronating, that means I probably may be having a stroke on the left-hand side of my brain. So that's another very important sign to look out for. S stands for speech, so slurred speech. Okay, so anytime you see someone slurring their speech, and they may not be able to say words clearly, and they may be actually like if you've ever seen someone who's heavily intoxicated, who's trying to speak, and they're starting to slur their words. So it kind of looks like that at that point. Just something you have to watch out for. And T is the most important and underrated variable in this mnemonic. T is for time. So the reason, and I think this is a perfect segue in terms of what treatment is done for stroke. So the time, and especially for the students and the graduates, whenever you take a history for a stroke as well, the most important thing to ask the patient or the patient's relatives is, when did you last see the patient normal without these symptoms? Because sometimes patients can wake up with a stroke. Right? So it's very important to ask, when did you see the patient last normal without these symptoms? Because you have a 4.5 hour or 4.5 hour window to give intravenous thrombolytics, which are thrombolytics meaning thrombo meaning a clot, and lytic meaning breaking down. So these medications break down the clot. So you have 4.5 hours to give a medication called TPA, which is tissue plasminogen activator, which basically helps in breaking that clot away so it can restore blood flow. And you have 4.5 hours from the onset of symptoms to give that medication, which is why it's very important to ask about time. The quicker you can get the patient to the hospital and get that medication in, the more beneficial it is for the patient. As many studies have shown, it decreases morbidity and mortality and improves stroke recovery time as well the earlier you give thrombolytic medication.
Perfect. Now that's a wonderful way of recapping, or the symptoms and signs, and kind of, as you mentioned, talking about just the lead into the treatment, what's usually done. Now, I mentioned previously about atherosclerosis. That essentially leads to narrowing, but what leads to an acute episode would be, as you had mentioned, thrombosis. So when you have a break in the plaque, in the atherosclerotic plaque, and then you have the phenomenon of thrombosis that leads to the acute episode of a stroke. The atherosclerosis as such could lead to a symptom called as transient ischemic stroke, where you have symptoms for a duration of less than 24 hours, where it does not classify as a stroke. The symptoms resolve within less than 24 hours, but then moving forward, depending upon the percentage of stenosis, you would consider other things such as carotid endarterectomy, where you take the plaque out, or the the occlusion, resolve the occlusion. So just remember that as you're talking about it. Wonderful. Apart from thrombolysis, what are the things that are in the hospital? What are the kind of investigations that could be done? We'll just briefly mention and cover them.
Sure. So other than the IV thrombolytic medication, another thing that could be done is a mechanical thrombectomy. So
Right.
just to sort of give you an idea of what happens, if a patient is identified as having a stroke in the hospital, the stroke code is usually activated in most hospitals, which means a dedicated stroke team, a team of physicians and nurses and radiology technicians as well, and radiologists are a part of the stroke team who aid in identifying the patient, immediately taking them to a CT scan. And for all med students and graduates, if in any of your questions or anyone asks you, the best initial test to diagnose a stroke is a non-contrast CT scan of the brain. Not contrast and not an MRI. It is a non-contrast CT scan of the brain because it's quick and you don't need contrast in this case. Okay. So when you take a patient there, and usually sometimes ischemia, which means when there's a clot, the brain can appear normal in the early stages of stroke. It can also appear normal if the patient is having a transient ischemic attack, also known as a TIA, as Dr. Keith mentioned. So it can appear normal. The reason you're doing this is so that you can exclude a hemorrhage, which is a blood vessel that's ruptured and bleeding out. Because if a patient is bleeding out, you do not give thrombolytic medications because that will make the patient bleed out more. So you have to call neurosurgery usually to help drain the blood or the hematoma and repair the vessel or see what else needs to be done. If in fact you've ruled out hemorrhage and the patient is still exhibiting signs of stroke, which again, there is a criteria that you have to follow, which is the NIHSS scale. And after a particular score, it can be determined that the patient is having an ischemic stroke. You can administer IV thrombolytic medications and monitor the response. Sometimes, if the patient's exceeded the 4.5-hour limit or the patient has contraindications to IV thrombolytic medications, that's when you give mechanical thrombectomy. Mechanical thrombectomy is basically either through the radial artery or the femoral artery. What you do is first, this is for med students, and I love talking about this. It's called the Saldinger technique, where you insert a catheter all the way up with the aid of a CT angio to see where you're going. So it's guided, and where you can put whatever tools through that catheter, and you can directly enter the vessel. Once you enter the vessel, you can mechanically, using obviously microscopic force, not microscopic, but very tiny forceps, you can essentially take the clot out.
Yeah.
Retrieve it, right? So that's mechanical thrombectomy. Sometimes, additionally, the patient will have a blood pressure of more than 180/110, which can be classified as hypertensive urgency or hypertensive emergency if the patient has had signs of end organ damage. So in this case, this will be hypertensive emergency.
Emergency.
The patient having neurological signs.
Yeah.
In that case, you'll have to give them anti-hypertensive medications or blood pressure lowering medications. Again, for med students and graduates, always remember, do not give, you will see all sorts of beta blockers, ACE inhibitors, and all that. The best first-line medication, IV labetalol. Not metoprolol, not bisoprolol, IV labetalol. And as a bonus, if any of the med students or graduates watching this know why we use IV labetalol, post a comment below this video to tell us why you think it's labetalol.
Actually, that's a very interesting question. I personally do not know the answer as well, but is it something to do with the beta receptors themselves, or them being selective, non-selective? Is it based on a study? I don't know.
Could be, could not, but we will reveal the answer in our next video.
Absolutely. So put the answers in the comments, and I'll also join you in the comments. I'll have a think about it as well. Perfect.
Go for it.
Now, so that's treatment in general. Now, after treatment, obviously the patients have lost an aspect of function depending on which part of the brain is affected. But you can always try to help them in different ways in order to get them to a functional baseline. Not the normal baseline, but a functional baseline. Now, we all know that neurons are non-regenerating cells. So once they're damaged, they don't get regenerated. So how do we help them get to a functional baseline? I think there's a concept called neuroplasticity, where the different so if we have, let's say, 10 doctors, okay, and they do 10 different things. So each doctor represents a different function or a very vital role that they play in the team. If we have 4 doctors out due to some reason, we're essentially trying to run the show with 6 doctors, where you have the same functions. It might not run with the same efficiency. It might be at a compromised level, but you're essentially trying to work around things. So that's the idea of neuroplasticity, where you're not regenerating things, but using your existing abilities or existing functions to kind of cope with those things. So as you had mentioned, one of the things that could be affected are speech. Speech could be affected. Vision could be affected. Swallowing could be affected. Mobility could be affected. So essentially, the teams that we have are, teams that help with swallowing. It's called, for example, here in the UK, it's called the Speech and Language Therapy Input Team. So they have, they come up with recommendations. So they assess swallowing. For example, if the patient can only tolerate a certain level of fluid, a certain level of diet, we might add thickeners to, let's say, whatever they're drinking, so that it's a bit more easier for them to swallow. It reduces the risk of choking, aspiration pneumonia, and so on. And in terms of vision, for example, if the patient has hemianopsia, we'd have orthoptic input where you would be retraining, finding out what's wrong, seeing how we can best optimize the situation. You have OT input, so occupational therapy, where there's a dedicated team that goes to these patients' houses and sees what is the best way we can help them live independently. So it's the idea of, although you're dependent on a certain level, it's the idea of getting you to a place where you're comfortably independent by yourselves. And physiotherapy is another very important vital bit where you have certain exercises that help you retrain yourself and get you back to a functional baseline. So that's rehab in a nutshell. Anything you'd like to add on that? Add to that? Perfect. So that's wonderful. We've had a wonderful conversation today about stroke. We've had a few questions that we've put out. Please feel free to put in your answers. We'll reveal the answers in the next session. And that's it from us today. Thank you so much for listening to us, and we'll be coming up with more interesting stuff. If you have any suggestions regarding topics or just in the way we present or anything you'd like us to talk about, please do let us know. And anything you'd like to add, Maja?
I think that was perfect. And I hope this helps people identify strokes.
Absolutely.
And helps lives as well.
Absolutely. And always, if there's anything that you have medically or you're not sure about medically and you need medical input or something of that sort, always do get to your nearest doctor. I mean, this is a source of which this is more of like this is a way of information or a source of information, but it's always good to kind of visit a doctor in person or tell your doctor in a way that he can directly assess your symptoms and can look at your background and can give you accurate information that's specific to yourself. So that's it. Thank you, and we shall sign out, which is
Sir.
Nani.
Namaskar.
Pakala.